Hi, thanks for having me. My name is Giten. I work with Trade Asia. I'm based in Bangkok. I work as the manager for community and policy at Trade Asia. I've been involved in the access to medicine treatment in the Asia Pacific region for quite a number of years. Started with HIV and then have been involved for a long period of time on hepatitis C. From the recombinant interferon to pegylated interferon to first generation DAAs and now to the second generation direct acting pan-genotypic regimen work. So viral hepatitis, both again on B also, we're doing quite a bit of work. So have been involved in this for a long period of time. I also serve in the strategic advisory group for WHO in Southeast Asia region. What else do? I also am a guidelines development group member for WHO, the headquarters for the global guidelines on hepatitis B and hepatitis C. I served as an expert advisory group member with the medicines patent pool in Geneva. I also am in the Drugs for Neglected Diseases Initiative, which is a Swiss foundation based in Geneva. I work as access committee member there. That's a voluntary basis work. Also, I've served on committees, technical committees of the WHO Western Pacific Regional Office. So I play multiple hats and represent my organization and the region in different platforms in relation to access to different medications and policy-related work on HIV and viral hepatitis.
Do you think the eradicating of hepatitis, viral hepatitis B and C by 2030, is it possible?
That's a difficult question, and whether or not we will achieve elimination, it's not eradication, it's elimination. Okay. So of viral hepatitis is something that every country is actually moving forward to. The global community has set clear indicators and targets on how to achieve these and what would define achieving of this elimination targets. There are researchers who are working on it, and not many countries are actually on track of eliminating hepatitis C, or almost non-existent for hepatitis B. None of these countries who are in the pathway of elimination are actually in the region of Asia Pacific, except for something like Australia, for example, high income country, although they're in Asia Pacific if you define it by the UNAIDS way of looking at how you define a region. But having said that, I think the point is we all should work together, the community, the government, the different policy makers, the international community, technical organizations, health institutions, academicians, medical professionals. So we all have to come together towards putting up programs that are beneficial towards a public health response of a particular country, for that matter for Nepal, that everybody comes together to make sure that we are going ahead, we are implementing programs, and we're putting policies in place to achieve elimination of viral hepatitis by 2030. We don't have an option because we have made an international commitment to achieve elimination by 2030. We might not be able to achieve everything by 2030, but that doesn't mean that we don't start or we push ahead. So, whether or not we'll be able to achieve is a difficult question, yes, but we cannot stop. That's it.
In case of Nepal, still, the complete treatment for hepatitis C is like 80,000 rupees Nepali. It has quite come down to some extent, but still it's a big amount for Nepali populations. So what do you think about the affordability and accessibility of the medicine in South Asia countries?
So we look at hepatitis B in this section. We look at hepatitis B as one and hepatitis C as another. So two sections because we require different medications for treating these infections. Now, if you look at hepatitis C, many countries, low and middle income countries have access to generic formulations. Now, many countries are again using the Global Fund procurement mechanism to purchase hepatitis C related medications. So We look at the pangenotypic regimen, which is either sofosbuvir and daclofenavir or sofosbuvir and velpatasvir. So that's the pangenotypic regimen that we are considering now. We don't use most of the other drugs that were there earlier, which require genotyping test. If you look at soft DAC, you're getting it around $33. And mechanisms are always available to procure these medications. National programs are getting it at $33 or lesser, depending on what sort of exchange rate you're looking at. Soft velpatasvir approximately is around 95 US dollars. Global Fund is also helping in terms of procurement of these medications. I mean, the Global Fund procurement mechanisms are there. So it's up to the governments. The suppliers are there, the medications are there, the roads of actually getting these medications are available. The pricing kind of reference is always established. So it depends on the country, government and the ministries of health or the health agency which is procuring these medications, number one, to negotiate on how much of these medications they're going to need, what sort of projection they're having in terms of diagnosing and treating people. And then negotiate and get the best price for their national program. So saving money in terms of procurement and diagnostics means that you'll be able to provide greater coverage. That's one. So accessibility in terms of Hep C, it's all there. I think almost for all the Southeast and South Asian countries, the medications are available in generic formulations for hepatitis C, both soft daclofenavir and soft velpatasvir. That's one. In terms of affordability, based on your question, we're getting it at approximately $30 for soft DAC and $95 for soft vel. So it's up to the national governments to look at those those reference pricing and then see what best they could go for and set a ground for negotiations based on the procurement mechanisms that they're going to use. So that's for hepatitis C. Hepatitis B, we either use tenofovir, disoproxil fumarate, 300 milligram, or we use tenofovir alafenamide, 25 milligram, or we use entecavir, either 0.5 or 1 mg. So these are the three, based on the requirements of the person who's going to use it, these are the three medications. Now, tenofovir, TDF, is an off-patent drug, so anybody can, there's no longer any patent on this medication, and if there is manufacturing capacity in the country, that means that multiple manufacturing companies could actually, any pharma company could manufacture it, provided they have the kind of, facilities that they need for this and the kind of infrastructural support. That is going to cost approximately, if you look at the HIV related or the Global Fund price, it's costing around $24 per person per year. So in terms of accessibility, there's no intellectual property related barriers, and in terms of affordability, that's $24 per person per year. Compared to an HIV drug, which is fixed dose combination of TLD, that's around $57 per person per year, I think. And $24. It's up to the national governments as to what they're looking at and what sort of a mechanism or what sort of a pricing and volume they're looking at to get this or make this available at their public health program. So these are not very big. Yes, TAF or entecavir have some limitations in terms of generic formulations and availability. TAF is available, but entecavir is not widely available, especially entecavir syrup, which is used for mainly pediatric formulations. So to me, it's more of policy decision or strategic investments that needs to be made with proper forecasting for a country in terms of what they would, what the national government best feels, meet their requirements. Now remember that all the indicators for viral hepatitis, when you say elimination of viral hepatitis, it's applicable both for hepatitis B and hepatitis C. It's not only for hepatitis C. So we've focused a lot on national programs for very good reasons on hepatitis C, but hepatitis B is something that should not be forgotten.
So what could be the pathways for Nepal to move towards the elimination of hepatitis as a public health threat by 2030?
I mean, it's from what I understand, Nepal has already had its strategic plan on viral hepatitis elimination. That's one that's developed. Hepatitis C related diagnosis and treatment guidelines for the country has been developed. There are things that the government is taking up in terms of providing a certain amount of support to treat people with hepatitis C, with HIV infection, co-infection, or without co-infection. There are other organizations like SPARSHA, Recovering Nepal, who are doing their bit to make sure that people are getting diagnosed and people are getting treated for hepatitis C. So that pathway is really good as a starting point. But if you look at the timeline and you want to maximize your outcome by 2030, perhaps we can focus much on programs which are already in existence and which has a very well structured human capital, infrastructure, diagnostics, and also kind of resources that are already available. And with that, I could mean also HIV program or the TB program, which most of us work with very closely. Harm reduction programs are very well structured. These are areas and platforms or programs where we can just integrate some of the services which are mainly meant for prevention or providing treatment, and engage the community of the high-risk groups, including people who inject drugs, men who have sex with men, sex worker, work with everybody to get first the low-hanging fruits. So we're not trying to reach out to a general population first, which are harder to get. But then, if you look at the prevalence rate of hepatitis C infection among people who inject drugs, it's pretty high. I'm sure it's the same thing for Nepal. And that can be easily reached through the harm reduction programs or the HIV-focused programs which are already in existence, which are funded, which has the manpower, which has infrastructure. So that could be something, that the government could work with the communities to, capitalize on these existing resources and platforms. Simultaneously, of course, general population needs to be reached out to, specifically for hepatitis C. For hepatitis B, absolutely, the antenatal, program, the reproductive health program. All of those programs play a very important role in terms of vaccinating newborn kids or, infants or children with the hepatitis B related 3-dose vaccination. All of those are important, but I think the first step, besides the one which is around prevention among newborns for hepatitis B, I think it's really important to focus on existing programs and trying to integrate as much as possible, which I think evidently comes up first is the HIV program or the harm reduction settings.
Do you see any role for high-risk group like people who inject drugs or any vulnerable groups or key population?
Absolutely. I mean, that's precisely what I was saying. So, in the HIV response, if you look at it, if there's a high coverage or, a lot of the 1990 targets globally, we were almost there, and then we increased it even to 95 as bold targets. It has a lot to do with, the community or people living with HIV movement contributing to that process. The same is applicable for hepatitis C, B, or C both. If we are going to work on achieving hepatitis C related targets or hepatitis B related targets, yes, definitely we have to work with the high risk groups. Especially if you look at hepatitis B from a prevention point of view, normally the general trend is you look at an infection or a disease and look at the prevalence rate and you respond based on those numbers, and policies are designed based on a very high prevalence. Hepatitis B, because it has got a very effective and safe vaccine, we have to look at it from the other way around. Globally, only 4.5% of people who inject drugs are living with hepatitis B, which leaves 95.5% of people who inject drugs still susceptible to hepatitis B, means they could be protected. So those people, easily through the harm reduction sites or through the drug treatment centers or to methadone or buprenorphine dispensing sites, needles their insides, they could easily be prevented from getting a fatal liver disease and related mortality some years down the line. So I think these are important things that we should look at. Hepatitis B is a completely different ballgame. We should absolutely look at hepatitis B from a prevention point of view and the opportunities that are there, and how the harm reduction programs for the people who inject drugs, and definitely other high-risk group key population programs could play a very important role in this. And this is something for the government to recognize. We can look at the HIV program for to check the indicators for this and success of these. And I'm sure the community will step up and work with the government, with the institutions, the medical facilities, physicians, the national program to make a very clear outline and plan to achieve and progress towards the elimination targets.
Thank you very much.
Thank you to SPARSHA, and thank you to everyone who's going to watch it. Any comments or any questions that you may have, please feel free to send a question to SPARSHA, or I don't know if there's going to be a comment kind of a thing in this thing. Please send those as questions. Happy to answer.